Thank you, everyone, for joining our spring edition of the DBS Ambassador virtual educational event. I'm Hannah, and I'm a clinical research coordinator at our Movement Disorder Center. And today we're going to be hearing from Dr. Lon Lowe and Dr. Ron Alterman, who are part of the DBS neurology and surgical team here, as well as from three of our patient ambassadors who have undergone the procedure themselves. If you have questions throughout, please go ahead and use the Q&A box at the bottom to enter them. And then after each presentation, we'll have time at the end for all of your questions. And the first portion of this meeting will be recorded with the presentations from Dr. Lowe and Dr. Alterman, so you can go back and watch on our YouTube channel afterwards. So we'll go ahead and get started first with a presentation from Dr. Lon Lowe, who is a faculty member in our division and the medical director of our DBS program. She joined us after her fellowship in epidemiology training at Columbia University Medical Center. And prior to that, she completed medical school and adult neurology residency at Baylor College of Medicine. She was awarded a Parkinson's Study Group Mentored Clinical Research Award for her research focused on localizing a brain circuit for Parkinsonian gait dysfunction using structural and functional connectivity. She was also awarded the Early Stage Career Investigator Award from BIDMC. Last year, she became the medical director of our DBS program. And with that, I'll turn it over to you, Dr. Lowe.
Thank you so much, Hannah, for that introduction. I'm very happy to be with you today to give a brief overview about deep brain stimulation for the three indications of Parkinson's disease, essential tremor, and dystonia. The information I provide here is just a brief overview of DBS, and I do encourage you to chat more about DBS with your neurologist or DBS specialist to discuss some of the details. And I want to say that one of the beauty of our movement disorder program here at Beth Israel Deaconess Medical Center is that we have this DBS Ambassador virtual event. And this is where you can get to hear from patients who've underwent DBS surgery. And so you really get that firsthand experience from the ambassadors to discuss the details of this process and the procedure itself. So with that, I wanted to proceed here. I want to let you know about my disclosures and conflicts of interest. I am involved in two clinical trials at the moment, one of which is the Abbott Deep Brain Stimulation Post-Market Study of Outcomes for indications over time of their virtual deep brain stimulation platform, as well as the Neuroderm ND0612 subcutaneous infusion of carbidopa-levodopa. I also do some consultation and advisory board activity for Mitsubishi Tanabe Pharma America, as well as the Fortis Medical Devices Limited. However, these will not impact my presentation today. In terms of deep brain stimulation, this gives a cartoon of what DBS is. These two leads that you see there in the deep structure of the brain are called the DBS electrodes. This then gets connected to, this is the burr hole cover, which you see is the circular area on the top portion of the brain. And then subsequently from the burr hole cover, you have a connector cable that then leads down into the chest. This is a battery pack, or otherwise known as implantable pulse generator, which powers the deep brain stimulation device. In this case, in this diagram, this patient has two IPGs or two battery packs. It is possible to just get a single battery pack, which can power both sides of the electrode on the left and the right side. So I want to discuss some factors that set patients up for successful outcome after deep brain stimulation. So some of those factors include appropriate selection of patients at the appropriate clinical window. In terms of Parkinson's disease, the appropriate window would be about 4 years or after of the diagnosis of Parkinson's disease. If you wait too long before getting deep brain stimulation, that could potentially make you not an appropriate candidate. For example, if some symptoms such as cognitive impairment set in, and if there is already severe cognitive impairment to the point of dementia, then we would not recommend DBS surgery. Of course, having reasonable expectations after DBS surgery would also play a part of the outcomes after DBS surgery. Accurate electrode placement. Of course, here at BI, we have a wonderful neurosurgeons, Dr. Alterman and Dr. Aronson, who would help with this portion during the surgical planning as well as during surgery itself. And of course, careful programming, which include regular follow-up visits that would be on a monthly basis after the surgery, with the first 6 visits back to back in that monthly intervals after the initial surgery. And then, of course, long-term follow-up with your DBS specialist is another key to success after the surgery. So in terms of setting up some realistic expectations for what DBS can or cannot achieve, first of all, deep brain stimulation is not a cure for these various disorders, such as Parkinson's or essential tremor or dystonia. It can improve motor symptoms such as tremors, dyskinesias in the case of Parkinson's disease, which is a medical term for fidgety movements or involuntary movements of the body. Dystonia, which is a abnormal posturing of a particular part of the body, motor fluctuations, slowness, and stiffness. One thing to keep in mind is it does not slow down the disease progression. And then furthermore, it does take some time to achieve the best results. And again, this is done through those back-to-back programming visits, which are spread out over a period of 6 months after the surgery. For the case of Parkinson's disease, the response to DBS would be estimated to be as good as your response to the levodopa or dopaminergic medications. This is true for most symptoms of Parkinson's. However, in the case of tremor, there are some patients who do well after DBS, even if they don't respond to levodopa medication. And of course, for Parkinson's disease, one of the major issues that may lead people to consider deep brain stimulation is that they want to reduce or potentially discontinue some of their dopaminergic medications. However, this, while could be achieved with STN DBS, it should not be a primary goal in some cases. Just to clarify that last concept, with STN DBS, that is DBS done to a particular part of the brain called the subthalamic nucleus. In this case, most patients could reduce their dopaminergic medications after surgery. However, this should be a very slow process and is done with the guidance of your DBS specialist. So I want to talk further about Parkinson's disease and deep brain stimulation. I mentioned before that you have to have some realistic expectations about what DBS can and cannot achieve. So some of the symptoms of Parkinson's that DBS can help with include tremor, stiffness, slowness, wearing off episodes. This is that yo-yoing effect of the dopaminergic medications. For example, there is the on state in which people will do pretty well after taking each dose of their carbidopa, levodopa, and then they go into that dip or a wearing off period, which their symptoms are not well controlled with medications. And then finally, dyskinesias or uncontrolled involuntary movements of the body. That's another area where DBS will likely achieve a good result after surgery. So some of the symptoms that will not be changed by DBS include freezing of gait. This is a term that's used to describe when the feet are being glued to the ground. It could last for a few seconds, and then this can occur in certain situations, such as going through doorways or while turning. Other symptoms that are not well achieved with DBS include balance, memory difficulties, hallucinations, having a softer voice, and difficulty swallowing. So you can think of these symptoms as being the axial or central symptoms. These are kind of going symptoms that are in the center of the body. These are usually not well controlled with deep brain stimulation. And then for the case of essential tremor, deep brain stimulation will be able to help reduce tremors, such as those in the limbs, postural tremors. So meaning when you have tremors in a certain position, such as with the arms outstretched, or tremors that occur when you are holding the hands like this. And then it could also help to reduce sometimes the head tremors. The symptoms that are not achievable with DBS in essential tremor include voice tremors, poor balance, memory loss or cognitive dysfunction, and or hearing loss. And then the third diagnosis in which DBS is done is something called dystonia. This is, again, what I mentioned before, is that abnormal posturing of one part of the body, which can include, for example, curling of the toes. Sometimes it's a flexion of the fingers, which can be seen in primary idiopathic dystonia or dystonia sometimes related to Parkinson's disease. For this case of dystonia, symptoms such as excessive pulling of the muscles, abnormal posturing, or pain related to these postures will most likely improve after surgery. The best candidates for dystonia in terms of DBS include those with primary idiopathic dystonia, certain genetic forms of dystonia, including DYT1 mutations, and those with drug-induced dystonia. And then on the other hand, those symptoms that are not going to be changed by DBS include certain types of secondary dystonia or those with rapidly progressive dystonia. So here at Beth Israel Deaconess Medical Center, we do take a multidisciplinary approach for DBS evaluation. What that means is that you will get evaluated with a team of experts, including a movement disorder DBS trained specialist, such as myself, Dr. Simon, Dr. Shi, or Dr. Merchant. Our neurosurgeons here, including Dr. Ron Alterman, as well as Dr. Joshua Aronson, a neuropsychologist, a speech therapist to get a baseline speech evaluation. This is usually an optional evaluation, but it is recommended in most people undergoing DBS evaluation, as well as potentially meeting with a social worker or psychiatrist in certain cases if the clinical scenario would prompt those meetings. This evaluation typically takes about 2 to 3 months to complete all of these appointments, as well as getting a MRI scan, a detailed scan of your brain. So I wanted to talk a little bit about those DBS programming visits and what do we mean when we say describe these programming visits. So a programming visit usually happens about 3 to 5 weeks after your brain surgery. This usually takes about 1 to 1.5 hours in duration. For Parkinson's disease, these visits are typically done in the off medication state or holding your medications for about 12 hours before coming into that visit. For the very first visit, we check the surgical incision sites to make sure they're healing nicely, as well as in checking all the electrodes and contacts to make sure there's no issues with any of those placements or impedances. And then subsequently, we would increase the stimulation in a stepwise manner, very slowly, until we see the maximum impact or until there are any side effects that could be observed. So we can actually adjust your settings in a very stepwise manner so that we can better control the tremor, stiffness, and slowness in the scenario Parkinson's disease. Or we could also try to help reduce those tremors in the case of essential tremor, or provide you with benefit for the case of dystonia. And then keep in mind that as we're titrating your DBS programming settings, potential side effects could occur, but these side effects are usually transient or temporary fashion, and we can tweak the settings so that those side effects can be ameliorated. So what do I mean by when I say the different parameters can be changed with DBS programming? There are three components that we can change, and those are the amplitude, which is the intensity of the stimulation that's delivered to the brain. The pulse width means the duration of each electrical pulse that's being delivered. And then finally, we could change the rate at which the number of pulses of stimulation are delivered per second. So we can tweak any of these three parameters. And actually, as you can imagine, each parameter has several different ranges that we can tweak, which comes out to actually several million of different combinations of these settings that can be used. One of the major changes that we can do is tweaking the amplitude. That usually has the most impact in terms of the clinical outcome. And then, of course, those follow-up visits that happen on a monthly basis, I mentioned before, usually the first 6 visits will usually be lined up and scheduled. That will happen after the DBS surgery. And then in these follow-up visits, we would tweak or optimize the stimulation slowly over time. We can adjust accordingly in order to gain the most clinical benefit while avoiding DBS side effects. And these can take anywhere between 6 to 12 months in order to find the appropriate settings. And this time frame can vary, so depending on your clinical presentation, that can take either a shorter amount of time or a longer period of time. For example, in the case of Parkinson's disease, getting to the appropriate setting can take anywhere between 3 to 12 months. While for cases like dystonia, that could potentially take a longer period of time. So anywhere between 6 to 12 months would be a general estimate. So a lot of times people will ask me, what are the newer advances in DBS technology? So I wanted to bring up directional DBS stimulation. And this is a technology that came out back in 2014. And all the 3 major DBS manufacturers, including Abbott, Medtronic, and Boston Scientific, they have directional DBS stimulation and directional DBS leads. So what this means is that in the top diagram, you see a traditional lead. And if the third contact counting from the bottom, the third contact gets activated and it's used as a traditional ring format, then the stimulation would be almost like a ring-shaped stimulation, all the way 360 degrees, all the way around that lead. However, with the directional technology, if you look at the center of the bottom panel, we could eventually actually just activate a portion of the lead so that we're getting a more precise and more accurate stimulation to a particular part of the brain. If you look at the sweet spot, that's the area in green, while the sour spot is the area in red. So the goal of our DBS programming is that we try to deliver the stimulation to the green area while avoiding the stimulation to the sour spot or to those red areas. The sour spot, if we stimulate there, that could potentially lead to adverse events, such as, for example, tingling sensations, sometimes causing slurred speech, or potentially pulling of one part of the face. However, with the directional stimulation, we're able to help achieve that more precise and more targeted stimulation. So another advance in DBS technology is rechargeable batteries. All three manufacturers do have a rechargeable battery option. So with the Abbott, this just came out a few months ago. That's their Liberta rechargeable IPG or battery pack. For Boston Scientific, that's displayed in the middle. That's their Vercise Genus R16 battery pack. And the Medtronic has a Percept RC or the Activa RC rechargeable battery. So these have some slight differences, but overall, in terms of rechargeable batteries, this could be a good way to go if you're someone that's able to recharge on a weekly basis and remember to do that pretty well. It can take anywhere between 30 to 60 minutes per week to recharge your DBS. So depending on the individual and depending on your particular clinical scenario, the rechargeable battery may be a good option for you, and it can eliminate the need to get more or additional surgeries. For example, if you had a non-rechargeable battery, you would potentially need to get a replacement battery surgery done about anywhere between 3 to 5 years or so. And then I also want to talk about another advance in DBS technology. Medtronic has a brain sense technology, which is able to capture brain signals, or otherwise known as local field potentials, within the implanted lead. This is available on their Percept platform. And this is technology that's embedded in the Percept lead as well as the Percept battery pack. This just means that there is a possibility to record some of the surrounding brain activities while the DBS therapy is being delivered. And clinicians can then correlate these brain signals with the stimulation and patient captured events, such as medication intake, your particular symptoms. For example, in the case of Parkinson's disease, patients could track whenever there is an emergence of tremor and or potentially side effects from the stimulation. So overall, this is one of, for example, Medtronic's advantage of their DBS platform. And then this is just a Samsung clinician tablet that just shows you what these brain waves look like on the graph. And then we will look at this data to look at the beta peak in this graph, then which can tell us if there's an emergence of those Parkinsonian symptoms, such as tremors or slowness and or stiffness of the body. Okay. And then finally, there are a lot of information about DBS on the web. There are some more reputable websites to get information on deep brain stimulation. For Parkinson's disease, that's the Michael J. Fox Foundation. There's also the Parkinson's Foundation that's listed here. For the diagnosis of essential tremor, there's the Essential Tremor Foundation. And then dystonia diagnosis, you have the Dystonia Foundation. So these are very reputable sites that I would encourage you to look for more information about DBS. So with that, I will stop sharing and turn it over.
Thank you, Dr. Lowe. I'll go ahead and send out a recap email after with those links as well in case anyone missed it. But now I'd like to go ahead and introduce Dr. Ron Alterman, who is our Chief of Neurosurgery at BIDMC and Professor of Neurosurgery at Harvard Medical School. He's one of the first surgeons to perform DBS surgery in the US, and he's now performed more than 1,700 new DBS implants in the last 25 years. He's an international thought leader on DBS surgery and has published more than 100 articles and book chapters on this subject. Thank you for joining us, Dr. Alterman. I'll turn it over to you.
Hi, everybody. I'm going to be relatively brief, and then we'll allow people to ask questions. I don't have a fancy presentation. I think Dr. Lowe covered, many of the important aspects. In terms of how we do the operation, it's like skinning a cat. Every neurosurgeon has, or stereotactic neurosurgeon has their own beliefs about how best to do it. And the most important thing, I think, is that it are the results that the surgeon gets. And our results over the last 30 plus years, speak for themselves. As Hannah said, I've been doing deep brain stimulation since before it was even approved in the United States, and prior to that was doing a lot of pallidotomies for Parkinson's disease. And the reality is that while there have been a lot of inventions and newer methods introduced, the way I personally do the operation is very similar to the way I was doing it way back when. I still, and way back when meaning the mid-1990s, the Clinton administration. I still use the stereotactic head frame. It's the gold standard. The mechanical accuracy of the frame is 1 millimeter. The newer Lexel frame, which came out 3 or 4 years ago, has made some modifications that make it even better than it was, but the accuracy is still there. We rely on microelectrode recording a lot less than we did in the early days, and a lot of that has to do with the fact that we learned so much about targeting from microelectrodes from those recordings that the more senior folks who do this, like myself, have are very comfortable about where we think the electrode needs to go. The fact that we don't have to do microelectrode recording has freed us up to do the operation asleep, if that's what people prefer. I still prefer to do it with the patient awake. And the reason for that is that I can gain more information. The brain itself doesn't feel any pain. So as long as I numb your scalp, I can get a lot more information from test stimulation in the operating room. That said, I would challenge Dr. Lowe to tell me which patients I've implanted awake and which ones asleep based on the programming. The results seem to be pretty much the same. And so if you tell me you want to be asleep during the operation, I'm happy to do that. I don't use the ClearPoint technology, even though we have it available. And the reason for that is that the operation, the way I do it, even with you asleep, is much more efficient. And I can confirm very, very quickly about electrode position with the CAT scanner that I have in the operating room. So it's actually faster in my hands and with the same exact accuracy and results. In days past, we would stage the electrodes. We would do one electrode and then wait a month and do the other electrode and the generators. We now do everything on one day. And I think the reason for that is we're so fast and efficient. I think the big challenge was preventing air from getting into the head while we were doing the recordings. And we really don't have that problem anymore. And so again, it's more efficient from your standpoint in that you don't have to come back multiple times to have one electrode only implanted or 2 electrodes. And I know even some centers that do 1 electrode A month later, they do the second electrode, and then 2 weeks later, they do the pulse generator. And so it's 6 weeks before you have all of your hardware implanted. And nowadays, we do it all in one shot. I definitely have moved towards the newer devices do have certain advantages. The segmented electrodes can help with steering current, although there's no substitute for proper positioning of the electrode. And again, the newer pulse generators, one device for both electrodes, again, which reduces the amount of surgery you're undergoing. You have the rechargeable options. Although a lot of patients like the idea of just putting in a device, not having to worry about recharging it for 5 or 7 years, and then coming in for half a day of surgery to replace the battery. So it's more of a set it and forget it kind of thing, as opposed to having to worry about recharging, even though the rechargeables do last much, much longer. So that's really it. We're very flexible again. It customize the operation to the patient, both in terms of target, technology, asleep versus awake. And so, the way we do it is quite efficient, very low risk. Our complication rate is as low as can be, and that's the most important thing. These are elective operations that are designed to improve your quality of life. And so you have to get through the operation without a major complication in order to enjoy the benefits of the stimulation going forward. And so the most important thing is to get the electrodes in the right place without hurting you before we go ahead. And with that, I'll open it up to questions if anybody has any specifically for me. Here we go. I'm looking, I see, let's see. Can you swim with a battery pack? Dr. Lowe is typing the answer. The answer to that is absolutely. Once your skin is healed, everything's under the skin. Your skin is watertight, and yes, you can swim. Get wet, do whatever. How long does electrode implantation surgery take? So in my hands, as I described, we start at 7:30 in the morning with putting the head frame on, and my electrodes are usually in by 11:30 in the morning, sometimes even quicker. So the actual time on the operating table is about 2 to 2.5 hours. If you're awake, and if you're asleep, obviously it doesn't really matter. You're in and out pretty quickly. But yeah, typically from 7:30, putting the frame on. We usually make the initial incision by 9 o'clock. So that allows for the imaging and the targeting to be done, for me to do the targeting on the software. And then we get started with the formal operation, typically around 9 in the morning, and both electrodes are in 2.5 hours. Anything new and exciting coming down the pike? I would say that depends on who you speak to. I think the newer stimulation devices are incredibly small, easy to implant, easy to recharge. I think that's been very exciting. I think we've learned a lot from the Percept device, which allows us to record from the brain. In terms of other technologies, I'm a little more skeptical. You may have heard a lot about iPSCs or pluripotent stem cells and implantations and transplant for that. I know that they just implanted the first patient at the University of Arizona, Tucson, with another company that's also doing iPSCs. I've written about this, and I really don't think that that's going to be the answer. And it's probably going to take a decade before we find out whether or not it's really better than deep brain stimulation. And my guess is that at best, it will only be as good, and it takes at least 2 years until you realize that full potential, whereas we can put the electrodes in and within a couple of weeks turn your device on and you get the results right away. So I don't see transplantation in its current forms as being a technology that will supplant deep brain stimulation as the surgery of choice for Parkinson's disease. And the same with essential tremor. There's really nothing new for essential tremor for those who are here.
I can answer the biomarker question.
Sure.
So I'm going to read out the question. Is there any biomarker that helps you decide who is the candidate for good prognosis after DBS? So this is a great question. I'm actually doing a research project with Dr. Bruno Benitez in order to answer that question. One of the things that we're working on is actually It's called the DBS Biorepository Study. That means collecting some biological samples, which can include blood samples or potentially saliva samples before DBS surgery is done, as well as after DBS. And this way, once we can analyze the information there in terms of proteomics, metabolomics, transcriptomics, and then figure out if we can find any biomarkers that can lead to great outcomes after the surgery. And then I can also do the other question regarding someone asked, what are the outcomes of DBS and person with a GBA mutation for Parkinson's disease? Someone has read that there are some indications that the outcomes can be poor. So for this question, there's actually for GBA mutation in Parkinson's disease that can lead to an increased risk of developing cognitive impairment. So for that, I would advise getting a detailed neuropsychological evaluation in order to determine if there's any potential baseline cognitive problems, which may or may not make you which could make you not a great candidate for DBS surgery. So I would say that you should definitely proceed with caution, and then it would depend on the particular clinical scenario for that case.
Okay. And I can take over. Let's see. What about a 4-implant surgery? How long? 2 battery packs? Question mark. So that was how, when you say 4 implants, I'm assuming the person means 2 electrodes and two pulse generators or 2 battery packs. That is a way one could still go, although I do that far less than I used to. I used to prefer the 2 devices, keeping them separate, and that was mostly because of fear of infection that infection on one side would not affect stimulation to the other. So the 2 devices were completely separate from each other. There is danger that with 2 electrodes going to 1 battery pack, that if you get an infection, it'll contaminate both sides and then everything will have to come out. The reality is that our infection rate has become so low that I'm really not worried about that as much anymore. And so, if a person had a particular desire to have it, the older configuration, I'm happy to do it that way. But I really don't see it as being a major, I would say the vast majority of my implants now are 2 electrodes to one of the newer battery packs. Next question was, any fear of post-surgical complications? Sure. Anytime we're doing surgery, especially brain surgery, we're worried about post-operative complications. And as I said, because this is not a life-saving operation per se, it's a quality of life improving operation. We're really beholden. The onus is really on us to minimize the risks so that you can go on to benefit from the stimulation. And I've spent my entire career, in fact, if you look at the body of work I've done, most of it has been about how do you do the operation better, safer, faster for the patients. And our personal record, and we've published it on this in the last couple of years in particular, about electrode implant accuracy, about infection rates, about all kinds of issues, is that we've really minimized the complication rate for this operation. So yes, it's something to be considered, and we have to discuss it. I mean, in terms of what the main potential complications are, the first one that we worry about is bleeding in the brain at the time of the electrode implant, which of course could be catastrophic, right? A major brain hemorrhage can lead to death or paralysis or coma. In our hands, that risk is less than 0.5%. And the last time I had a serious hemorrhage predates my arrival in Boston. So it's 15 years ago, back when I was still at Mount Sinai in New York. Number 2, infections. Our infection rate is less than 1% now. So again, that's the second thing we worry about, although that tends to be less catastrophic and more of an inconvenience in that we have to pull out, remove the hardware that's contaminated or infected, let you heal, treat with antibiotics, and then we can reimplant. poorly positioned electrodes. Again, extraordinarily rare in our hands. Occasionally, we've had cases where, despite best efforts, we weren't happy with the response or the position of the electrode, and we've gone back and repositioned the electrodes, but that's probably on the order of 1 to 2% as well. And then device malfunction is, again, extraordinarily rare. We've had occasional wire breakages, but now, again, the devices are engineered so much better than they were 30 years ago that's really not an issue anymore. The next question, is this an accurate review? DBS provides the possible opportunity to extend quality of life as the Sinemet begins to weaken its effect. Yes, that's exactly correct. It's not a replacement for Sinemet per se, and it simply is there to enhance or to smooth out the variability of one's response to Sinemet. We can't do better than best Sinemet response, except for perhaps tremor or getting rid of dyskinesia, the side effect of the medication. But if you're not responsive to levodopa, deep brain stimulation is likely not going to help you. Is there any estimate as to how long I can expect to have benefits? 2 years, 5 years, 10 years? That varies on patients because it has to do with progression. But what I can say is that we have excellent data at 5 years and very good data at 10 years on average, that patients still 10 years out are doing better stimulation on versus stimulation off. But obviously 10 years later, the disease has progressed. So you're not going to be as good 10 years hence as you were in the first year after stimulation. And then other symptoms that I'm sure Dr. Lowe mentioned, I know I signed on late, that don't really respond well to deep brain stimulation, mostly gait disturbance and cognitive decline. Those are the most significant and disabling features of advancing Parkinson's. And as those symptoms set in, then the benefits of deep brain stimulation will become less significant. But how fast that happens, or if that happens at all, is dependent on your particular disease state. Every Parkinson's patient is different. Let's see, Lon took one. Let's see, one patient writes, I was diagnosed with PD 8 years ago. I have very little tremors, primarily slowness and dystonia. Realizing each case unique, would I benefit from the surgery? Potentially, yes. Dystonia and bradykinesia, slowness of movement, are two symptoms that do respond well to deep brain stimulation. And so, yes, that would be something to consider.
I can take the next one. So
Sure.
this is from someone who says they're pretty fit at 73 years old and diagnosed at age 60 with slowly progressive, I'm assuming it's Parkinson's disease. Then would DBS be a reasonable option? So yes, I would say definitely reach out to your neurologist or DBS specialist about that question. And then they can also discuss with you further about your candidacy for DBS surgery. And then if you are a candidate, then proceeding with the workup that I mentioned before, meeting with the multidisciplinary team, including the DBS specialist and neurosurgeon, and then proceeding with the workup, yes.
What kind of batteries do we use? Are they? No, they're the batteries that the manufacturers use. We don't have the option. I believe they're all lithium-ion batteries, although the rechargeable is probably some sort of capacitor because it's not a battery. And they're perfectly safe. These devices have, like I said, well, the Medtronic devices, 30 years plus of excellent track record. And the other two device manufacturers, Abbott and Boston Scientific, are, giants in the field of medical implant devices. So the devices themselves are extremely safe. Someone else, I think the question was taken off, had asked about what the electrodes are made of.
Yeah, I answered that.
Oh, you answered that. Okay.
Yeah, it's
great.
a platinum iridium. I had to look it up actually, but it's platinum and iridium alloy.
Yeah.
All
And
those.
then it's all biocompatible. It's all been tested, all
Right.
FDA approved.
Yeah, and then that
Uh,
goes along with the next question, I think, regarding how long do the electrode last, and it lasts for several years, several decades that I know of. So those are pretty durable equipment.
Yeah, they're designed to stay in for life unless they break
Hmm.
or get infected or something like that. But no, they're designed to stay in for life. And then following up, someone has said no, they meant 4 electrodes. In Parkinson's disease, the two targets that we use, STN and GPI, generate essentially equivalent results. And I know some people have published on putting in 4 electrodes, and I've never seen the need for that or the benefit. So yeah. Then someone asked, how dangerous is it to perform surgery on a patient with low platelets? It depends on how low the platelets are and why the platelets are low. If they're mildly low, we can always give a platelet transfusion at the time of the implant, at the time of the surgery, and that should get you through. If you have very low platelets because of severe medical illness, a cancer or something like that, then obviously we have to worry why would we do um, an elective operation for quality of life if you're that sick. So if it's a mild uh, platelet thrombocytopenia um, uh, that's chronic, we can deal with that. Seeing this tool rise throughout your career, do you see ways of reducing costs of these devices from a physician standpoint? And hello from Dubai. Well, hello back. We don't set the price. The companies set the price. My guess is it's probably cheaper in Dubai than it is in the United States. Device manufacturers like the drug companies tend to use the US market to subsidize the global market for medications and devices. But perhaps Dubai is expensive as well. It's a wealthy country. No, it's really not up to us what the device, what they charge. We do our best to reduce costs overall for doing the surgery, especially in the US, because the way that in the US, the cost of the device comes out of the hospitalization cost. And so the more expensive the device, the less money there is for actually doing the surgery. So I'm always trying to reduce things in any way that I can while still doing the operation, as well as it possibly can be done. In terms of low platelets or the patient's norm, again, what number are we talking about? If it's over 80,000, we're probably fine. Does Medicare or other insurance pay for DBS? Yes, absolutely. Particularly for the approved indications, Parkinson's disease, essential tremor, and dystonia. DBS does not affect non-motor symptoms, as far as we can tell. And Dr. Lowe is typing an answer about age. I think the patient's overall health is more important than age. Obviously, once patients get, in my mind, over the age of 75 and certainly over the age of 80, we have to be very, very careful and make sure that we're doing the right thing. But no, I've done deep brain stimulation on people in their 80s who were otherwise robust and they've benefited. So.
Yeah, that's what I mentioned. It depends on any medical comorbidities. If someone has a lot of diabetes, hypertension, hyperlipidemia, or coronary artery disease, that would, increase your risk with any surgery. So
Thank you, everyone, for a lot of really great questions. Like I said, I'll send out a link to the recording for this first part, and you should also be able to scroll through the Q&A and look at the answers that were typed. So thank you, Dr. Alterman and Dr. Lowe, for joining us as well. And then now we'll go ahead and turn it over to our patient ambassadors.